it's a public seminar, so we're pleased to see a significant number of people from the community, people who don't work in this building and don't work on brain tumours here today. And we've got two talks, one by a local person and one by a special visitor from the United States. Hopefully they'll be able to tailor their talks to things that you can understand in ways that you can understand. So this seminar is put on by Mark Hughes Foundation and Hunter Medical Research Institute. My name's Steve Ackland. I'm the Director of Hunter Cancer Research Alliance, which tries to facilitate everything to do with cancer research in Newcastle. And I'm also, for my sins, the Chair of the Scientific Advisory Committee for the Mark Hughes Foundation. So the Scientific Advisory Committee are charged with the task of advising the Mark Hughes Foundation about how to spend their funds, particularly where it comes to supporting research into brain tumours. I can tell you that it can be a struggle when you've got a whole lot of competing interests and you want the Mark Hughes Foundation to get the best return on their investment in brain tumour science. So before we begin, I'd like to acknowledge the Awabakal people, who are the traditional custodians of this land, and pay respects to their elders past and present and in the future. If you need a loo, go out the back and round the side, they're over there. If we need to exit the building, just follow the exit signs, but it's never happened yet and I suspect it never will. All's good. So the first speaker for the afternoon is Mike Fay. Mike is a radiation oncologist who previously trained in medical oncology, but he's left that to other people to do now. He specialises in brain tumours. He works at Genesis Cancer Care at Lake Macquarie Private Hospital, and he has a role in Genesis Cancer Care for the state, and I've forgotten what that is, but he might mention that. He's fundamentally a New Zealander, but we won't hold that against him. He's doing a PhD in brain tumours. So this is part of his PhD, and you'll be able to score him towards his PhD at the end of his talk as you see fit. He is also the holder of a Mark Hughes Foundation Clinical Research Fellowship, so we're very pleased that he's taken on that fellowship, and he is a member of the Scientific Advisory Committee. The second speaker, who I'll introduce later, is Susan Chang from the University of California, San Francisco. She's not an American, I think. I think she's still a Canadian. Yeah. Isn't that clever? Right. and if she's got any sense, she'll be going home via Vancouver, because you can get into the States much quicker if you go via Canada. So anyway, I'll introduce Susan a bit later. So without any further ado, let's hear what Mike has to say. Oh, and by the way, do you want to say what we're doing? This is Facebook Live. So if you ask a question, don't be afraid. It's going direct to air, and there might be 1,000 other people watching you or listening to you on TV. So
just listening to you. The camera's facing this way.
Yeah. Camera's facing this way. So I've already embarrassed myself on the internet. We'll see how it goes. Okay, thanks.
Thanks very much, and thank you all for coming on a Saturday afternoon. I'm going to talk a little bit about PET imaging and some of the research we've been doing. As Steve pointed out, I'm still a PhD student, and when I was in Germany at EKUT, they thought I was the world's oldest PhD student, so hopefully it will be finished soon. So why work on brain tumours, and particularly why on glioblastoma? Well, we pulled out some data from Queensland when I was working in Brisbane and looked at 2,656 patients. And this is the survival curve for GBM. So there's clearly a lot of work still to be done. And based on this data, the 24-month survival was about 10%. Now, the good news is that when we looked at it again for just the past 5 years, the survival had increased significantly, so it was then sitting about 18 to 20% at 2 years. But it's one of these things where, it's an uncommon tumour, it's 1% of the tumour burden but it really is a disease that has a huge impact. A lot of young patients, at least $50 million a year just in Australia in hospital costs alone, and there's huge costs quite apart from that. The treatment outcomes are often poor, and even small incremental improvements can significantly improve survival. So I'm sorry this is a little confronting, but this is to show you a glioblastoma and the way it's infiltrating into normal brain up here, and then tumour with little bits of necrosis and nastiness. So we go from the sort of gross tumour level down to microscopic, and there's this kind of invading front of tumour cells. And a lot of the smart genetics people around the world now are breaking this up into more and more groups, and we're looking at genetic markers, and this is helping us an awful lot break things into smaller areas. Simplifying this down, there's patterns that are being recognised. So there's some mutations in EGFR, there's mutations in IDH1, and so these tumours are sort of fitting in more into patterns. This is not quite flowing through into therapy, but part of what I want to do today is talk a bit about how that might be linked. And the problem largely is still local control. So if you look at the area where the tumour comes back in the brain, in 75% of patients in this study, that was actually in field. It was the area that got full radiation dose. So 3/4 of the recurrences are occurring in exactly the area where we've treated. So again, a little confronting, I'm afraid. This is an attempt to improve local control by using a drug called ALA. So what surgeons do is give the patient ALA prior to surgery, and then they turn all the lights off in the theatre and they put a special coloured light on, and the ALA goes into the tumour and then fluoresces. So that you can see here there's an area of necrosis, there's an area of tumour, and then it's a little bit unclear, but basically the surgeon's job then is to safely take out as much of the tumour as they can. Now radiotherapy has come a long way. When I started training in radiation 20 years or so ago, this is what we were basing treatment off. So plain X-ray, you can just make out a craniotomy sort of in there, and you sort of aim for the middle of it, and things were, a lot more hit and miss than they are now. CT scanning helped us a lot. You got a much better view of the craniotomy, but not a very good view of the brain, unfortunately. We still use CT a lot because it helps us work out the radiation doses within the brain. But really it was MRI that's revolutionised things, and I'm sure Susan's going to talk more about MRI. But that has really helped us an awful lot in terms of outlining the tumour. But the area that I'm sort of more excited about is PET imaging. And I wanted to talk a little bit about PET because this ties together two types of technology, nuclear medicine or PET, as well as CT. And this is a combined PET-CT scanner. So the first agent that was sort of widely available was a labelled form of glucose, or 18-FDG. And the problem with this for brain tumours is that all of the brain lights up. So for a high-grade brain tumour, like a GBM, it's not particularly helpful. For a low-grade tumour, this patient had a low-grade tumour in here, it can be quite helpful because you can see a cold area within the hot rest of the brain. But it was really the development of new types of traces that helped us a lot. So now we have amino acid traces that can go just to the tumour area and tell us where the tumour is most active. Just flick back to this slide here. So this was a patient with a low-grade tumour who then developed something that changed, an area that went bad, if you like, and that can then be helpful if you see a hot area inside a cold area. But mostly now we're relying on new technology using amino acid imaging. And so the combination of MRI scanning, PET scanning, and then fusing it together, we can get a much better idea of what's scarring, what's cyst, what's active tumour. And I just wanted to show you from a radiation point of view how this can be helpful. So in radiation you try and outline where the tumour is, which we call the gross tumour volume. And looking at this MRI scan, you'd sort of think that area there was looking pretty nasty. But when we did the PET scan, it was clear that the bit that was actually worse was just in front of there. So if you were basing your radiation treatment volumes just on the MRI, you might well miss the area that is likely to cause problems. The other thing we're finding is that things are popping up on the other side. and there are these association fibres that go across from one side of the brain to the other, and quite often we're seeing this sort of thing happening. This is another patient who was really quite hard on MRI to see where the tumour was, but then when you do the PET scan it becomes quite a lot more clear. So we have been having a look at this across a whole lot of different tumour types, so high-grade glioma, anaplastic astrocytoma are not quite so high-grade tumour, but a little bit less common. And we're particularly bothered by this problem of pseudo-progression, which is when the tumour looks like it's getting worse after treatment, but it may well be a combination of a whole lot of things: leaky capillaries, breakdown in the blood-brain barrier. And so with some colleagues at CSIRO in Brisbane, we've been having a look at combining MRI scans and PET and getting a much clearer idea. And certainly 4 weeks after chemoradiotherapy, it's now quite a lot clearer using this sort of technology what's happening. So this is an idea of some treatment response, and so on MRI there's a nasty looking tumour there, but at 4 weeks post chemotherapy and radiation, it's interesting that the PET scan's showing, the areas that are causing problems are really sort of outside that area. And then when you look at the MRI subsequently, another 12 weeks down the track, it's certainly the area that's being suggested on the PET that looks like is progressing, not the other sort of areas. The other thing that we've been quite interested in is this concept of multiplexing, so it's looking at different types of imaging together. And one of the techniques had been to look at hypoxia, so areas of the tumour that are not getting enough oxygen. And you can do this by using some modification of the PET technique and giving the different traces at different points in time. I'll just come back to him. So the idea is that there's an area inside the tumour which is a long way away from the blood vessels, and that's not getting enough oxygen. Now, this is a problem because the tumour cells around this area can be quite resistant to radiation. So what we've been doing is using a drug called F-miso, which is a PET tracer that lights up areas that are not getting enough oxygen. And when we've been finding patients who have F-miso positive and then also the amino acid PET being positive, that's a particularly bad combination. So the other thing that seems to be associated with resistance in brain tumour treatment is raised pressure. So these abnormal blood vessels around the tumour tend to be leaky. You can see a lot of fluid that's leaking out around here. And one of our very smart CSIRO people come up with an algorithm which can look at interstitial fluid pressure, and we find that that's also an area of high pressure. So I guess we're getting to the stage now where we can look at a whole lot of different characteristics of the tumour, if you like. We can look at blood-brain barrier breakdown, we can look at metabolism, we can look at formation of new blood vessels, we can look at proliferation and even low oxygen, and perhaps if the tumour starting to die off. So with a combination of all of these things, it's hoped that over the next few years we'll be able to uncover some of these resistance mechanisms. So I wanted then to move on to how we can use this therapeutically. And apologies for the not particularly great slide, but there's a new type of treatment called Theranostics, where you find a target somewhere on the cancer cell, which is specific to the cancer cell, and you then tie that to a payload, which is usually a radiation emitter. And instead of radiation given traditionally as external beam, this is given by injection and then floats along, matches up with the tumour cell, and hopefully causes it to die. And we think that that causes a lot more damage to the cancer cell DNA than if we give it from the outside. So this is a much fancier graphic of the sort of idea. So you have a sort of marker sitting on the outside of the tumour cell, and then you have something that targets that. So one of these things that's been used in prostate cancer is something called PSMA. Now, unusually, one of the patients that's been scanned for prostate cancer turned up something in their brain and turned out to have a brain tumour. So it's been shown now that PSMA is upregulated in some brain tumours. And this is quite a neat way of scanning, because you don't need a whole lot of the infrastructure that you need for a normal PET scan. It doesn't require a cyclotron. It's relatively much more easy to do. The other thing is that you can tie things together, so you can have an antibody and then you can have a cage and then you can put a radiation emitter in here, both a diagnostic one, as we saw in the picture before, or you can put a therapy molecule in as well. And so this is this paper that first showed some of this work. So what we've been trying to do locally is go back through the Mark Hughes Foundation Biobank, and Paul Tooney and a group in our lab has been having a look. So this is a piece of normal brain tissue. It's been stained and it's all looking fairly normal. That's a tumour which we've also stained with PSMA, and so we're seeing that around. It looks like it's around the blood vessels. We're just in the middle of confirming that. We're getting a lot of this PSMA uptake. But the other thing we're finding is that there is PSMA uptake sometimes more generally through the tumour. Why are we doing this? Well, we've got a drug that we can use already that we're using in prostate cancer, so a radiation emitter that attaches to the end of PSMA. So if we find that a significant proportion of patients have this, then we might have another line of treatment. So this is a study that's just about to start, which has been supported in its development by the Mark Hughes Foundation and is being sponsored by Genesis Care. And that's looking at doing two types of PET scanning, the amino acid scanning and then the PSMA PET scanning. And we're hopeful that this will give us an idea of how many patients are likely to have increased uptake, and then hopefully we can develop some therapy based on that. So this is just the outline of the scan protocol. So this study is just about to start in Newcastle this week. We would like to do a therapy trial where we give this high energy radiation emitter, and we've been trying to get funding from the government, and they're interested but say that we need more data before we can do that. So this is the idea for a clinical trial. Now, just jumping back a step, one of the other things that we've been looking at is ways of trying to screen molecules for activity in helping overcome treatment resistance. And this, in a previous life, was used intraoperatively as a breast radiation device, and we've managed to get it to work so that we can put cell cultures in a little dish at the top. And the great thing is that we can look at a whole lot of different radiation doses in 96 wells all at the same time. So it's really giving us a way of doing sort of high throughput screening. So this is the situation that we've got at the moment, and thank you, Paul. I'll finish this slide from you. So we've got radiation causing DNA damage, but then that damage is being repaired. So it's not that the damage isn't happening to the tumour cells, it's more that that's being reversed. And this is happening through ATR and DNA PK activation, and the end result is recurrent glioblastoma, recurrent brain tumour, and poor survival. So what we're hoping is if we can get in with some inhibitors, that we can inhibit this DNA repair, and the glioblastoma cells which have already been damaged will then go on and die rather than growing back. So this is a very busy slide, and I apologise in advance. What we're trying to do really is to tie a whole lot of information together. So really important to have clinical information, medical imaging, pathology. Increasingly we're finding genetic information, so genome, and then what happens to the genes once they're transcribed into proteins, the transcriptome and the proteome, and then what genes are turned off, and try and turn all of this, put all this data together, see if we can also see if there are tumour cells floating around or DNA floating around, and then see if there are surface markers that we can find, and this then gives us the opportunity to develop Theranostics, these drugs that are targeted to specific things. So thank you. These are some of my collaborators, lots of people here locally, and particularly want to thank the Mark Hughes Foundation and their amazing support over the last few years. Thank you.
Thanks, Mike. So there's no such thing as a silly question. Anything is fair. Just by way of explanation, the word theranostic has two parts. One is therapy and the other is diagnostic. So the way that is conceived in science and medicine is that you make a molecule that you can give to a patient where you can work out where the molecule goes. So that's the diagnostic part of it. Or if you give a bigger dose, because in this case it's radioactive, or it can be made radioactive, it can actually be treatment for in this case, brain tumours. So that's what Mike's on about. So not only will he develop molecules that can be used as PET tracers and facilitate the diagnosis and the actual mapping of where the tumour is, but then with a little bit of tweaking of the molecule, you can make a treatment as well.
Yeah, it's a little bit like a magnet on the back of the molecule, so you can put either a diagnostic radiation emitter, which is low energy, or you can put a very high energy one on the back of it.
The little minute doses of radiation that you attach to these biomarkers that travel around, do they sort of finish up all over the body everywhere, or they do manage to make it to the intended target?
Yeah, look, that's a really good question. So the ideal theranostic goes exactly to where you want it to go to, and it doesn't have much what's called off-target binding. So one of the problems in prostate therapy has been that people, their lacrimal glands light up, and so then when you give treatment, they also get a dose as well. So ideally you want something that's only on the tumour and not on anything else.
Lacrimal glands make tears. So if they're affected by the treatment, then you'd get dry eyes, and that would be a problem for people.
The other thing is there's sort of a Teflon coating around the brain, and sometimes that causes trouble for these molecules. So one of the experiments we did was sort of make the molecules bigger and bigger and to sort of see if they can still get into the brain. And we found that once they got past a certain size, it took 6 or 8 hours for them to get across, and they didn't get through in high concentrations.
So these are short-term isotopes that only last for what, 24 hours or something?
Yeah, the half-life of most of them is in the range 2 to 6 hours. But the other thing is the cameras are becoming so sensitive that you don't need very much, a very, very tiny dose. Nanomolar concentrations are enough, so yeah, and that decreases the side effects.
We used to worry maybe 10 or 20 or 30 years ago, and some people still do worry about the amount of radiation patients with cancer or patients being monitored for cancer might be getting from things like CT scans, because there's a lot more radiation from a CT scan than there is from a plain X-ray. But the radiation dose that is actually given is now much smaller than it used to be. So I think the fear or the concern is largely going away.
Mike, one of the problems that we have with looking at brain cancer with the MRI scan is, as you pointed out, knowing if the cancer is getting better or getting worse. So do you think the PSMA scan might help us with that decision as well?
Yeah, look, that's completely unknown at the moment. We're hopeful that, so the state of the art, I guess, is using PET scanning, leftover amino acid sort of based scanning. We don't know how quickly those molecules on the outside of the cancer cell get recycled or disappear, and how that correlates with activity. So I think that's why we need to get some more data.
Okay, good. If you have any more questions for Mike, there'll probably be an opportunity at the end. It's now my pleasure to introduce Susan Chang, but before I do that, let me just say that a few things about the management of brain tumours in Newcastle. We would have roughly 80, maybe 80 to 100 new patients with brain cancer in this area in a year. This is from the Hunter Valley mostly. Their surgery would be at the John Hunter or Newcastle Private, or now also at Lingard Hospital, according to where the neurosurgeon thinks the best place to be is. And things like radiation and chemotherapy are generally given either at the Mater or at Lake Macquarie Private. We have a multidisciplinary team that most of us attend, not necessarily regularly in my case, where surgeons, pathologists, radiologists, medical oncologists that give chemotherapy, radiation oncologists that give radiation, attend and discuss patients and make decisions about what's the best treatment for people. So that's pretty much what we do locally. In terms of research, there's research conducted in this building and in various other sites. There's some clinical trials. Mike gave you an example of a clinical trial there, and I think Susan will be talking a bit more about clinical trials generally in her talk. We always try to find clinical trials because we know how bad the outcomes are or can be for people with brain tumours, and we're always looking for things that are better. And that we will continue to pursue that with a high degree of vehemence, shall I say. And hopefully people in the future will do better than people of yesteryear in terms of outcomes for their brain tumours. I'll introduce Susan now. So she's Canadian. She did a medical she grew up in British Columbia, I think, right?
I actually grew up in Trinidad.
Trinidad, did you? Oh, okay, there you go. You've got around a bit. Anyway, I think medical school in British Columbia. And then she went and did medical oncology at Princess Margaret Hospital in Toronto. And one person that is one of, if you like, the grandfathers of Canadian medical oncology encouraged her to go to UCSF and do a stint in brain tumours, which at the time I think was relatively not well studied and not much treated by drugs. So she did that, and I don't think she's gone back. So she's gradually grown the program at UCSF, San Francisco, and become world-renowned as an expert in the management and the research of brain tumours in various ways. One of the things that she's done is develop a caregiver program, and we were particularly interested in that aspect of her work, and she will talk about that in a minute. And part of the reason is because we've struggled with the idea of how we support patients and their carers, patients with brain tumours and their carers in this district. As I've tended to describe, there's at least 4 hospitals, there's at least 3 or 4 different types of specialists involved in the management of people with brain tumours, and it always seems like a heaving sea, or it can seem like a heaving sea to patients, and it can be a struggle to work out how to negotiate and get the best care in that sort of a situation. And so the Mark Hughes Foundation has been funding a position called Brain Cancer Care Coordinator for the last few years, and we've got 2 young women, both of whom are off doing something else today, a wedding or something. A wedding, yes. And they job share in this position now, and we have found it quite valuable in that regard, and anecdotally most patients and their carers find it's been quite helpful. But we were wondering what other sorts of models of care for people with coordination of care for people with brain cancer might be available around the world, and how to think about evaluating this, and that's one thing that Susan will talk about. The other thing she'll talk about, I think, is clinical trials in brain tumours. So over to Susan. Thank you very much for coming. We're very grateful for you coming all this way. By the way, she's given talks in Brisbane earlier in the week or last weekend, and in Sydney, and here today. So thank you very much.
Thank you very much for inviting me. It's really a pleasure to be here. I think it's my 4th time in Australia, and I always enjoy it. So I'm going to start with the Caregiver Program first. And this really got generated by patients and families. So this is the Gordon Murray Caregiver Program, which is what we have at UCSF. I'm the medical director, but we have a core team, and I'll talk to you a little bit about how that evolved in terms of realizing the gap that was needed for taking care of our patients through the caregivers. So in terms of who and what an informal caregiver is, these are usually individuals, usually family members, who are providing healthcare for someone needing assistance, usually somebody who has an illness or chronic condition. And it's this act of assisting someone who's currently ill, has a chronic problem, who's unable to independently care for themselves, and that's where you get positioned as a caregiver. And what has changed over the last few years has made this such a critical aspect of why we need to be thinking about this in a much more purposeful way. And the first is the aging population and the fact that as our parents and our loved ones age, they're going to need a lot more help and a lot more care. Of course, with some of the neurodegenerative changes that occur as well and the chronic illnesses that people undergo, you can imagine how much of the caregiver and the family members become part of this person's care. But probably the other, I think, is the healthcare delivery system. Now, I've been doing neuro-oncology for about 27 years. And when I first started, when patients underwent a craniotomy, which is the operation you have to remove the tumor, patients stayed in the hospital for 5 to 7 days. And that was a lot of time to adjust, for the family to adjust, for people to interact with them, to try to help educate them about what to expect. And now a patient who comes in for a brain tumor operation usually stays about 2 to 3 days. So you can imagine this is a patient who was previously healthy. Usually they have a headache or a seizure or some event that takes them to the hospital, emergency room with their doctor. They get an MRI scan, and the next thing you know, they have a diagnosis of a brain tumor, and they undergo an operation. And then that patient goes home with the family member, and it's a family member who now has to figure out what about all the medications they're taking, who are all these doctors they saw, and who they're supposed to call when something happens or changes. What if they need physical therapy? What if they're weak or they can't talk or can't communicate well? What if they have reactions to the medications? These are all things that now the caregiver is responsible for, and we're not very good at sort of empowering those caregivers to be able to handle all of this work that they now have to do to take care of their loved ones. And so this fewer, shorter interactions with a formal caregiver or a healthcare provider can also make it very patchwork and fragmented in terms of how we take care of patients. And what about resources that are available in terms of things like outpatient physical therapy or speech therapy? And how are we able to mobilize those types of resources for our patients and to get the best care? Why is this important? Well, we've talked about new therapies for patients in terms of trying to improve their outcome. Usually it's survival we're hoping to improve. But we also have to focus on the patient's quality of life. What is it that this patient is important for them? What are their goals? And how can we improve their quality of life through educating the caregiver themselves? We also know that if we don't take care of the caregiver, they oftentimes have burnout. And so even caregiver health is something that we need to be paying attention to. And ultimately patient safety, so that these caregivers are comfortable with knowing when to call for help. They understand the medication profile, they understand the side effects the patient might exhibit, and all of those things are important to sort of, again, give that caregiver the resources that they need. We also talk about economic impact, so if these caregivers are more comfortable with what's going on, they can have them see the doctors earlier rather than taking the patient to the emergency room when things are a crisis. So all of these things become very, very critical when we think about taking care of the caregiver themselves. So what's clear about the caregiver experience, and this is just a snapshot, is that 75% of caregivers are employed. So it's not like they stop what they're doing to take care of the loved ones, it's an addition to. And so they're often having to come up with all of these skills to be able to harness all of that energy and information to take care of the patient. The skills that they need are a lot. You can see they range from being the supervisor of this patient and the medications, for example, problem solving, like I said, like when do you go to the hospital, decision making about the next steps, the planning, interpreting everything that's happening, direct hands-on care sometimes if the patient is weak, and then now you have to sort of help them move from bed to chair, for example. How do you negotiate the healthcare system? And I know, I can tell you from the United States, that can be very, very challenging. And how do you access resources? But in addition to this, I think for the caregivers of brain tumor patients, some of the things that even add to these challenges is the fact that we're dealing a lot of times with a very serious illness. It's a life-threatening in some cases. We have the neurological symptoms that occur in terms of weakness and difficulty with language sometimes, difficulty with vision, seizures, and therefore they may not be able to drive. But I think more importantly, things like the cognitive and behavioral changes that can be more difficult for people to grasp in terms of how do you handle that. The fact that it threatens the essence of a patient, the personality that the patient can change as a result of this, and some of the ambiguous loss and the anticipatory grief that caregivers can undergo. Another thing is the identity shift. So for example, if the patient is not able to drive, now all of a sudden the caregiver has to do all of the transportation of the family members and the children and so forth. So you can see how much of the shift occurs. And probably the most important thing that we've learned is this sense of isolation, the sense that who do I talk to about what I'm going through in my journey? Because we think of the patient and the family as one unit. And they're feeling that there isn't anybody that they can turn to. The feeling that when they come into the hospital or the clinic, everything's focused on the patient, which is appropriate because we're looking to see how is the patient doing, what does the MRI scan look like, what is the disease status. But it's the caregiver who then has to take that patient home and deal with any of the side effects of the medication and so forth. So this feeling that they're not given the attention potentially to give them the resources. So is anyone paying attention? I think that certainly in oncology in general, a lot of neurology, palliative care, geriatrics, a lot of people are figuring it out. A lot of the international organizations, and certainly the Brain Tumor Association of Australia, the Mark Hughes Foundation, the fact that next week in Australia is National Carers Week. So it's being highlighted on a national level about the importance of the caregiver. So what are the recommendations from the National Academy of Science to help us navigate how we sort of implement things for caregivers? And the first is this transition from this sort of patient-centered or person-centered to family-centered care. To really think about formally assessing the caregiver's risk, the needs, the strengths, and the preferences for that caregiver, being able to give them the counseling and the self-care and relaxation training and respite that they need to nourish themselves, to allow them to continue to care. And probably, I think, for what we feel is really critical is this education and skills training to improve caregiver confidence and resilience, and so that they're able to manage daily care challenges. And ultimately, we think this is going to help with the patient outcome. So how did this get started at UCSF? Well, it's always a collaboration, it's always teamwork, and the fact that there was an identified need. So the first was one of our patients whose family member, her husband, so the first patient is Ms. Damlatier, here, the lovely blonde lady. Her husband was a lawyer and elderly gentleman at the time when she was diagnosed, and he basically came to us after she passed with this incredible journal that he kept. For every day that he took care of her, he wrote down specifics about all the things he was doing. And he came with this caregiver, what was essentially a caregiver manual about, how he had to deal with the medications and how she was, her behavioral changes and so forth. And as a result of that, we developed the first orientation to caregiver manual for patients with brain tumors. And this is something that we've had now the second edition to incorporate things like clinical trials. And we're actually doing a third edition now to incorporate things like immunotherapy. Because as the field changes, the knowledge base that you're going to need as a patient, as a caregiver, is going to change as well. So we did that, and then the other thing that happened was, again, through a very grateful family, Gordon Murray, and Gordon is in the bottom picture here with his wife and 2 sons. And when he passed, his wife came to me and basically said that, we did a fantastic job with Gordon. We talked about clinical trials, we talked about options, but she really felt herself that she wasn't taken care of. And that was a big blow to me because, I'm very proud of taking care of our patients and I feel very privileged about it. But when I heard that we weren't doing a good job for her, it was kind of a wake-up call to say, well, what are we not doing? And one of the things she said to me was that, every time Gordon came in for a scan, he came into this hospital in the morning and had a scan and saw me in the afternoon with this MRI results to go over the scans. She said she sat there waiting in the waiting room, kind of alone. And here was an opportunity that we could have taken to interact with her as a caregiver, to understand what she was going through, to give us a perspective of what were things really like for Gordon from her perspective. And that was something that was a missed opportunity in terms of taking care of the patient and the family. And so she and her two best friends, and this is her brother in the middle, held a fundraiser, and from that proceeds, we were able to start the Gordon Murray Caregiver Program. So the first thing we needed to do was come up with guiding principles of what this would be like. It had to be integral, of course, to the care of the brain tumor patient. We wanted to develop quality caregivers. We wanted to vary the needs across, we recognized the needs vary across the trajectory of the illness, and we had to personalize the type of care that we provided to the caregiver. And recognize that the burden for these patients is higher because of not only the neurological impairment and the cognitive behavioral changes, but also that these caregivers tend to be very stoic, and they don't tend to call us about problems that they might be having. And so being able to be very open to tell them that it's okay to call, that that's why we're here, this is for them, sort of gave them that sort of permission to be able to call and lean on us to help them. And probably the most important thing was timing it right, so making sure we gave the right information at the right time. You can't give all the information at the beginning because you're not going to remember everything. So we really had to focus the type of information that we provided. And then we had to come up with a mission and a plan and what we felt were dedicated staff. So we have a nurse, Margareta Page, she's incredible. She's been a neuro-oncology nurse as long as I've been in neuro-oncology with me. And she has done a lot of work on fatigue and sleep and symptom management. We have a caregiver manager who really helps coordinate all of the work that we're doing. We have a social worker. And we just added a neuropsychologist to our group to help with family counseling as well. We had to go through a lot of legal risk and privacy issues because this was linked to the patient in a medical record. And so when you searched for that patient's information, you would actually see a field that talked about any sort of caregiver coordination, care coordination that we did with the family. And so that meant that anybody who accessed that chart could see who was the main primary caregiver to communicate with, were there issues that they were dealing with, for example, financially or with employment. What about were there kids in the home? Were they having any struggles? And so that ability to be able to embed into that patient's medical record what was happening from a patient and family perspective really helped the whole team to understand from a personal level what was happening. The key was also the seamless integration into the clinic, and we hoped, of course, that once we did all of this and we had a program that eventually we would extend it beyond UCSF. So I'm very pleased to be here to share this with you in terms of the work that we've done. So just to go through quickly, some of the models about caregiving. And the first is, this is by Sherwood et al. She's an amazing nurse who's looked at some of this work, about the fact that you have to think about what is the patient and what is it that the primary appraisal about how much care this patient requires specifically because of the disease. But then you do the secondary appraisal, and I think that's the part we're not doing formally now, we have not been doing, and now that's something that we are doing formally, which is what is it about the caregiver? What resources do they have internally? What are they strong at? For example, there are some patients that come in and they're very organized. They have a binder, they know everything about who the doctors were and what happened. And then you have some family members that come in and they're kind of like, they're stressed. They don't know how to deal with this, how they navigate things. And then some families have amazing networks. They know how to use the system. For example, there's an app called Lots of Helping Hands. And it's a way that their family members and their community can actually log on and say, okay, Tuesday they need help with taking the kids to soccer. And somebody could sign up for it. And there isn't this phone calling and sort of asking what's going on. You can just go on the line and actually map it all out to what that patient and family might need. So understanding all of that, and all of the emotional response, the physical response, the caregiver response, and sort of folding that all back in, each time there's a difference in the change of the status of the patient. So how you manage those patients at the time of diagnosis is going to be different than how you manage at the time of recurrence. And at the time when no more treatment might be the appropriate perspective for the patient. So this is just a snapshot of what we've been able to do in the last year, in 2017. The first is our inpatient program, and this was funded by another family through philanthropically to allow our nurse to actually go and meet with every patient and family member at the bedside when they're in the hospital with a binder that has information about their doctor, the team, the resources, the social worker, what to expect, and she also made up a DVD. We now have it on a stick, and it's actually on the web, about the disease itself and what to expect. What about the medications? What do they do when the fluid starts coming out of the incision? Things like that, so that they can anticipate that they have somewhere to go to help understand what the process might be. Every new patient that comes to our clinic, we encounter them, we give them resources, and we have a separate group of newly diagnosed glioblastoma patients where we're actually interacting with those patients and families every 2 months, so that we are calling, we're asking them what their needs are, we're checking in to see how they're managing, we're giving them more resources as they need. The other group, and you can see that's the majority, is this high-risk transition group. And this is usually a period of stress because the changes, either the patient gets admitted for some reason, they have to change strategies in terms of treatment, or they're going into hospice. And then the last is actually a group of patients that the family members that we call after the patients pass to make sure that they are actually okay in terms of their resources that can be given in terms of grief counseling, how are the kids doing. So this is something that we've started, and it really helps to close the loop for the family, but also for us. So we connect with them, we make sure that they're okay, and we try to reach out and continue to help them even after the journey. We also have a lot of education materials that we've developed. And because of the workshops and retreats where family members would tell us that they felt very isolated, we now have a support group that's dedicated to caregivers only. So we classically have had patient support groups where patients and family members would come together and we talk about updates about treatments and things like that. But what we found was that there wasn't really a forum for caregivers to talk about what they were experiencing, and that was a huge need, because that sense of isolation and lack of community was really stressful for them. And so now we have a dedicated time where the caregivers come together and they can talk about the fear that they have, the stress that they're feeling among themselves, and not feel guilty about it and not feel like they're isolated. And that's really been really critical. We also have a peer-to-peer connection. So we have family members who agree to talk to other family members, where we have this peer-to-peer, and we train them and we connect them as well. We collaborate with other professionals as well. So we also provide emotional support. We provide family support, including parental support. So one of the other things that we found out that we weren't doing very well was helping families who had young children in the home. We weren't providing them with resources. These families were struggling as to how to communicate what was happening with the patient to their young kids. And so we were able to pull together a lot of resources that we now have a packet that if we know the patient and family have young children in the home, we're able to educate them about how to talk to them about things. And then you can see the other aspects of interventions that we've offered as well. So we want to be able to prepare caregivers for what their journey is going to be. We want to decrease their distress, alleviate depression and anxiety, reduce the sense of burden, and to decrease isolation. These are the things that we want to be able to do for all of our caregivers. And our feedback and program evaluation is such that from surveys that we've done, the caregivers are telling us that what's most useful is information about the disease itself, the symptoms that the patients might experience, learning about the resources that are out there to help them, addressing the sense of anxiety that they feel, so it's not like they're feeling like what they're going through is unique to them, but they understand that this is part of how you handle or how you face this type of journey. The isolation and talking with children, and every patient caregiver who filled out the survey really believed that we had added value to care, to their care. So we want to extend the program from beyond UCSF. It's not very helpful if all we do is at UCSF, and that's part of why I'm here, to try to give some insight into how these care coordinators can actually leverage some of the resources we've been able to develop to be able to get this out. But we also work with the University of Pennsylvania, University of Alabama, to help them start off these types of programs not in the full way that we have, but certainly in smaller components of it. So what can you do in your practice, or what can we do? What can the Mark Hughes Foundation and the BTAA and the Brain Cancer Group do? These are things to think about in terms of being purposeful about the caregiver's perspective, recognizing the caregiver, acknowledging the support and the work that they're doing, and to identify and create new systems of support. So I've already sent emails to different people about all the resources we have on our website. It's all available, it's free. So we have manuals, we've had it translated into Spanish, it may not be relevant for you, but we're also getting it translated into Mandarin as well for our Asian population in San Francisco. So these are just ways that we hope that you can see maybe some parts of what we're doing that could be leveraged out and imparted upon some of the groups that you have here to be able to formally address the caregiver. So thank you very much.
Time for a few questions on that particular aspect.
Yes?
I'm just doing it for people with brain cancer, but all of this that you're doing is pertinent to people that have got other illnesses that affect.
Absolutely. You know, what your point is exactly right. In fact, any patient, and so I said, who is a caregiver? It's anybody caring for someone with a chronic illness of any kind. But what we're trying to do here is recognize that there are specific aspects about a patient with a brain tumor, in addition to all that caregiving you have to do, that you have to be aware of and recognize.
But there's nothing formal for people
anywhere else.
No,
I know. So that's right. So this is the only program I know in the world for brain tumor patients. I don't think there's even a program for anybody else.
No.
No, because I'm just going to be honest. From a financial point of view, to do this, right? If I see a patient with a caregiver, and I talk to the caregiver and dedicate my time to that caregiver, I can't bill, right? I can bill the patients there. And so that's why it was so critical that philanthropy is what jump-started this. Without the philanthropic support, there isn't any way we could have helped to create this kind of a experience for our caregivers. And so after this is our 5th year that we've had this program up and running. After 3 years, I went to the medical center leadership with my donors, and I said, this is what we've been able to do, and I ran them numbers, and I explained what we implemented and all the outreach we were doing, and they were like, great, we'll support your nurse, we'll support your manager, and we'll support your social worker. But it was only because we had a program in place that we could go to them and say, here are the results, and here's what we've been doing.
Because another way is, if the caregiver's being given support, the patient feels happier.
Of course.
And
Yes.
prognosis becomes better.
Exactly. The quality of life of the patient improves, and the quality of life of the caregiver improves too. So you have, because I think you're absolutely correct. I think patients feel that they're imparting a lot of responsibility on their loved ones as well. And so when they know that their loved one is supported, they feel like, okay, at least there's someone looking out for them as well as me. And I think that shift that we had to make was really, really critical. But it has been so rewarding to be able to do this. And it's like you say, how can we not be doing this all the time for all of our patients, right? Whether they have a brain tumor or not. And I think that is why I wanted to emphasize this National Carers Week next week, and that's for all carers. It's not specific to brain tumor patients.
It's also likely that the patient's utilisation of health resources would go down.
Yes.
So therefore, people who make the money are going to lose out.
Well, no, the shift.
Well, we'll find something else to do.
Yeah. No, the key there is that to me, it's really about making sure that you see the patient is taken care of the best as possible. And if you take care of the caregiver, you're doing that. That's really it, right? That's what the focus of all of this was about. Yeah. It's a good question.
So I have a question, Susan, and it's about the difference between the US health system and maybe the Australian health system. Traditionally here we've had a linchpin in the health system called a general practitioner, or you might call it a community physician, which I don't think exists much in the United States. And GPs here have been working in the community. They're usually the health practitioner of the patient and the carer in this context. So they have some insight into the family dynamics and various other members of the family and stuff. And part of their job has been to coordinate care and, refer people in the right direction for certain things and so on. I'd have to say, and you may or may not agree with me, that there's a deterioration in the position of the general practitioner in our healthcare system slowly over time. But how is it in the United States? Do you have things like community practitioners that do that?
So a lot of times this is run by internists, general internists, or who the practitioners are, essentially. And I can tell you that I don't think I've seen the same internist myself every time I go for a visit, because you don't have a person that you're connected to like we used to.
A big group practice.
It's a group practice, and you go and your sort of your record is in there, and they kind of figure they can learn from the record. So I think that fragmentation is one of the key problems. The other is, and I can tell you this came up, I just got an email from one of the attendees at the Cogno meeting I was at. She herself is a patient, and she was just saying how difficult it was when she had her tumor. She had to travel 14 hours to get her surgery. She had her surgery and she went back home, and there was nobody at home, nobody in her community to explain to her what she went through. She went home with weakness on her side. Her family had to take care of all of that. And so she was reaching out to me saying, what can we do to better prepare the patients and the families for when they get discharged? And I think our inpatient program is one that probably all patients and families should have the experience to be able to understand what it's like. So, yes?
I think it's a marvellous program. You've got three groups. You've got the patient, you've got the carers, and you've actually got the professional carers.
Yes.
Do you have a debrief for them?
Yes, so part of the medical record and why we have that link is that every time the carer is seen, it goes into the patient record. So our nursing staff and the physicians who's taking care of the patient knows what's going on. And if there's any sort of alerts from the neuropsychologist, for example, in terms of behavioral changes or stresses that the family's having, we get an automatic phone call, page, or an email about that. So that is all looped in and communicated as best we can. The other thing that we did was we recognized that when patients transitioned to hospice, a lot of times the hospice is in the home, that the hospice team that was going in, they're new to that patient. So what we've done now is we actually reach out to the hospice team and we share everything that we've been through with that patient and that family and who's the main caregiver, what are some of the issues that might be difficult for that patient and family, so that hospice team can go in and be familiarized already with some of the things to help that patient and family. We actually developed a professional manual for the hospice teams because we realized that the hospice professionals were not particularly good at taking care of our brain tumor patients. They were very good at nausea and pain and so forth, but when it came to behavioral changes and difficulty with language and how to manage seizures, they really didn't have that information themselves. And so I worked with a number of palliative care fellows to generate a manual where we use vignettes as examples of things that they might actually see when they went to the home to take care of the patient. So that was engaging the professionals as well. Yes?
The costs for a lot of these are high, and we always think about novel ways of delivering this kind of care. Using social media or virtual coordination, is that something that you're looking at as well to outside your catchment to try and see if you can help people in other sites?
Yeah, so once the patients are connected to us, then we do a lot of outreach by phone. We also have Telehealth, is now it's called. And what telehealth is that you actually interact with the patient and the family by video. They're not in the room with you, so they don't have to travel all the way down. And our neuropsychologist actually uses that for her follow-up interventions with the families and with the patients. So we are trying to make sure that we are staying connected as much as we can, because we recognize that not everybody can come all the way down to UCSF. So absolutely. Yes?
I was thinking back, the worst part, you go to the GP or wherever you go to, and they tell you, yes, all tests show that you've got A, B, C, or D.
Right.
And you feel isolated because you don't know anybody else who's got it. It would be so great if, there was, by the way, Fred down the road is willing to speak to you, they've got a similar problem.
Right.
And that would be great, or Frida. It would be great, but that doesn't happen.
Well, you have to make it.
It doesn't happen for a lot of things.
But it doesn't happen because people aren't purposely thinking about it. It doesn't mean that it doesn't exist. So, for example, in the United States, the American Brain Tumor Association has such a resource. We have a resource for peer-to-peer for patients, and we have the same thing peer-to-peer for caregivers. So it's a matter of connecting people and telling them that here's the opportunity. If you would like to speak with someone, we have people who've actually been trained to speak with you as well. But you have to put that in place. You have to vet all the carers and the patients who want to be able to talk to people, right? You have to have a directory where you want to match the same, maybe the age of the patient, the same disease of the patient, right? So that there's some comparability with that. But it means somebody has to do that.
Yeah. It would be great if somebody was at the grassroots level
Who did that?
who did that for everybody.
Right.
I mean, it might just be the fact that you're the one who's got a very funny finger, but the fact that somebody else has got it makes
Yes.
you feel better.
Yes.
That
isolation that you're talking about was something that resonated over and over with our caregivers. I mean, we're fortunate because our team, we have a manager, a program manager, who does all of that, who sets up the caregiver peer-to-peer and so forth. But you're right, it takes time, it takes
also you need a good
purposes,
population.
and you need a good population.
Whereas in Newcastle, right, there might be 6 of them with a similar thing. But if you're up at Warp, you're the only one.
But laying the groundwork maybe and having a link on the various foundation websites that says, would you like to connect to a caregiver? Right? And you click on the button and then it says, here, this is how we do it. But I think those are great ideas for how we can implement some of this that we're doing and get it more globally so that the caregivers feel supported.
So I think the Cancer Council helpline functions that way
No,
to some extent.
I'm not just thinking of cancer. I'm thinking
Sure.
of other illnesses.
Yes. Yeah. All right. Would you like to go on and tell us a bit
If
about?
everybody's okay listening to me for another talk. I don't know why it's not closing.
Just minimise it and then open the other one, and the program will stay open. Yeah. The minus minimise it, I think. Double click, it should be fine.
I know, it's like typical,
Struggling, isn't it?
Yeah.
typical Mac versus PC. View?
No, I think you just double click on it and it should open.
Sorry.
Okay.
There you go. Is it different one? No.
Just double click.
Oh, I was using this one. Okay, thank you. Wrong mouse. I don't know why there's two mice.
The other one's Mike's mice.
Two mice.
You got a mouse?
No, it's
Okay.
Okay, so taking care of patients is my passion, and obviously that's extended into taking care of the caregivers. But to do what I do and to continue doing what I do, it's the discovery part, and I think you heard very elegantly about some of the ways that you can use imaging to help with not only diagnosing patients but also treating patients. And so what I want to talk about a little bit today are some of the management strategies that we have and the clinical trials in patients with brain tumors. And I'm going to focus in on a lot of work we're doing at UCSF, but that's not to say that there isn't a lot of trials out there. So I'm just going to give you sort of a snapshot of the kinds of approaches that we're taking to deal with this disease. So I'm going to talk about drug delivery. How do we get the drug into the brain, which is where we need it to go? Targeted approaches, you've probably heard about this, precision medicine approaches. Immunotherapy, which is like the big deal now in cancer care. And then a little bit about viral therapy, where we're using viruses to help fight cancer. So if we look at the milestones in neuro-oncology, it's very clear, you've seen the graphs, it's very clear why we need novel treatments. And it's because over the last how many years, there's not been a lot of advances in terms of therapies for our patients. So probably the biggest thing was temozolomide, which was in the early 2000s here. Subsequently approved for newly diagnosed glioblastoma in 2005. The use of Avastin, or it's a bevacizumab, which is a monoclonal antibody, and this has been used for recurrent glioblastoma. And then we also have the tumor treating fields, which is a helmet. Are you all aware of this? How it's used? So it's a helmet that patients wear. It's connected to a battery pack, and you get this alternating electrical fields. And that's been shown in the newly diagnosed population of patients to improve survival. Approvals that's happened over the last how many years. So what I want to talk about is how do we move that bar? How do we get better about it? And it's through discovery, through a lot of work that's being done in basic science, and translating that into our patients. The first thing I want to talk about is the challenge that we have with getting drugs into the brain. And so convection-enhanced delivery is one way to do that. So you may be aware that there is what's called gliadel wafers. It's a sort of like a wafer that's implanted with a drug called carmustine. And what happens is the patient has a surgery, the tumor is taken out, and the surgeon places these wafers in the cavity. And the idea is that the drug leaches out into the brain tissue and is a chemotherapy drug, so it kills the tumor cells. Well, the problem there is that if you look at the concentration of the drug when you place it and how much of the drug penetrates into the brain, you're only getting it about 3 or 4 millimeters of the drug. And so the delivery of that drug into the brain is not very effective. So how can we improve upon that? Well, one way to do that is to actually place a tube directly into the tumor. This is directly into the brain. And you connect this to a pump. So rather than using diffusion, which is where you get a drug from a high concentration diffusing into a low concentration, you actually use a pressure pump to drive the drug into the tumor itself. And when you do that, you can see that you can get a much larger distribution of the drug delivered by this convection-enhanced delivery, or CED, as opposed to drug from just a distance of the source, which is the wafers. So this is putting drug directly into the brain as a mechanism. And here, what you'll see here is the fact that this is a clinical trial where we're doing this. And I'm only showing you the end result of a lot of work that was done in animal models, in canines that had brain tumors, all the way up into doing it in patients. So this is a patient with a recurrent glioblastoma. You can see the mass here. The catheter is in. We co-infuse it. Here's the catheter. We co-infuse it with gadolinium, which is a contrast agent you can see on the MRI scan. And you can see the drug being delivered real time into the area of the tumor. And so this sort of allows us to be able to visualize where the drug is going in the brain. And we now have a couple of clinical trials that we're doing this in. The first one is nanoliposomal formulation. So what a nanoliposome is a small molecule, a vehicle to embed a drug directly into this vehicle, and it allows the drug to leach out over a period of time. So it's a much more systemically driven in terms of the way the drug is distributed into the tissues. And so we're doing that in patients with glioblastoma, high-grade glioma. Usually the tumor has to be relatively small to be able to direct the catheter. And then we also have another clinical trial where we're using this agent called MDNE 55, and this binds to a receptor or a protein on the tumor cells that's unique to the tumor cells, and it causes this sort of dying of the cells because of the binding of this drug to the cell. So these are two studies that we're doing where we're actually directly injecting this into the brain using this convection-enhanced delivery system. So we know that cancer cells have a different way that they carry information and signal things for them to do, whether it's keep dividing, whether it's spread out to more parts of the brain, whether it's to bring in blood vessels to nourish it. These are all things that cancer cells have that gives it an advantage over normal tissue. And this complex aberrant signaling pathway is what we think is going to be important for us to identify ways to target the tumor. So if this is happening only on the tumor cells and not on normal cells, then if you shut that down in the tumor cells, the hope is that you can kill that tumor cell and prevent and spare the normal tissue. This has been very effective in some cancers. For example, with chronic myelogenous leukemia, that was probably the first type of drug where patients who had refractory disease, they came up with a drug that targeted only the cancer cells, and a lot of those patients went into remission. And now it's a standard of care for those patients. So it's understanding the biology, right? If we don't know all of these types of pathways that are abnormal, you can see that it would be very difficult to come up with drugs. But what's encouraging is that we have a lot of drugs. All of these are drugs that are developed to target all of these specific pathways to allow us to be able to test. The challenge with glioblastoma, though, is that one target doesn't exist on the cell, unlike some of the other cancers. We have multiple targets. And so all the single agent approaches of targeting these tumor cells have not been very successful. And that's because, if you think about it, if you hit, if these pathways are interrelated and you hit this pathway, well, this pathway is still ongoing. You hit this pathway, these pathways are still ongoing. And so this redundancy of the pathways make it very challenging for glioblastoma. But we now have a couple that are being tested in terms of those that are specific to tumors, glioblastoma. So this is one that leads to cell cycle arrest and cell death. The other is this TORC1 and 2, which is another inhibitor that we're testing to see if we can target these particular pathways. So these are ones that are ongoing, and this is just to give us a signal as to whether this might be important. And the goal would be then to combine these with things like radiation and chemotherapy ultimately. The other one we have is in a patient with low-grade glioma. So this is not glioblastoma, and this is where we're using a targeted therapy with chemotherapy, which is temozolomide, to try to avoid using radiation. So a lot of times our low-grade glioma patients are young patients. They might have disease in very important parts of their brain that if we give radiation, one of the long-term side effects could be effects on their cognitive and functioning. And so the idea here is to use this particular approach to defer when we do radiation. It's not like we're never going to do radiation, but if we can give patients a good quality of life without having radiation performed on their brain for as long as possible, then perhaps that will help with their cognitive functioning. And this is another targeted therapy that we're using in patients with grade 3 tumors, not glioblastoma. So I want to talk a little bit about precision medicine strategies. You've heard some of the work that's being done in terms of these biobanking and how important it is for us to take tissue out and try to understand what's happening within that tissue itself. So here's an example of a patient. Patient's 40 years old, presents with seizures, and if you look on this MRI scan, you can see this very large mass here in the middle of the brain. It's primarily on the right side of the brain. And then when you look under the microscope, you sort of see these cells that are abnormal. And if you've already heard how we use various different markers to try to figure out what the diagnosis is. And the reason why this is important is because in the past, the pathologist would look at slides, and if you set the same slide to 10 different pathologists, you might get various diagnoses for the same slide. So that was a problem, right? Because it's like, well, which one is it? Which one is correct? So there was that sort of subjective problem with figuring out what the diagnosis might be. And so the idea of using these type of markers is to be more accurate in terms of diagnosing patients with similar diseases that have similar outcomes, but also to help guide therapy, because you want to treat the patients with the most aggressive treatments, with the most aggressive tumors, and maybe the patients who have less aggressive tumors, we can be less aggressive so that we can maintain their quality of life. So what we now know about glioma is that we have various diagnoses that are based on some of these markers. For example, this one is called the IDH, or isocitrate dehydrogenase. That's just a long term for a gene that's mutated specifically in this tumor. In oligodendric glioma, we also now have this co-deletion of 2 parts of the chromosome, one on the first chromosome, chromosome 1, and the other on chromosome 19. That's commonly missing in oligodendric glioma, and that's a hallmark of the diagnosis of oligodendric glioma. So now the diagnosis of these patients with glioma is no longer whether there's a lot of cells and whether there's vascularity and all these other very subjective, descriptive terms. It's based on whether they have these very, very specific markers within the tumor itself. So we now have a diagnosis, for example, with this patient who is now IDH mutant HU2 grade 2, and you can see these molecular studies that are being done to really characterize the tumors. And why is that important? Well, it's important because we can actually now target some of these mutations. And this particular mutation, the isocitrate dehydrogenase mutation I was talking about, what we know happens with this tumor is that when the tumor has this mutation, the normal metabolism, so this agent called isocitrate gets metabolized normally in all our bodies to this drug, this particular metabolite called alpha-ketoglutarate. And when you have this mutation, this alpha-ketoglutarate gets shunted to a different metabolite called 2-hydroxyglutarate. So this is only in the presence of the IDH mutation. So what this means is that you now have a marker, 2-hydroxyglutarate, that is specific to cancer cells. It doesn't happen in normal cells because normal cells don't have the mutation. Only cancer cells have the mutation, and so you can use that to track whether your treatment is actually having an effect. But there are a number of trials now that are targeting this particular mutation, and so you can see how it's important that only the patients who have the mutation should go into these clinical trials, right? Because if they don't have the mutation, it's not going to work. So here is where selection of the right patient for the clinical trial becomes very, very important. The other basis of precision medicine strategies I wanted to point out to you is another case I have here of a 54-year-old gentleman. So he had a previous operation of a grade 2 astrocytoma in 2015. He was treated with radiation and chemotherapy, and unfortunately now the tumor has progressed and he has another operation. Well, the current pathology is now glioblastoma, and the hallmark of glioblastoma is these multiple, very, very dense cells. These are blood vessels here, and this sort of area here is called necrosis within the tumor itself. And those are all of the hallmarks of glioblastoma. And we know that glioblastoma under the microscope could look the same from patient to patient, but if you actually did the molecular genetics of these different tumors, you actually pick up differences in the types of genetic makeup that the patients have, the tumors have. And so you have now these biological subgroups of glioblastoma that are driven sometimes by IDH, and in this case, this patient had a grade 2 that became a grade 4, which is glioblastoma, as opposed to a patient who shows up automatically with a grade 4. And if you look at the genetics of those two groups of tumors, they look very different. Under the microscope, they look exactly the same. They're called glioblastoma, but they're not the same when you look under at the genetics aspects. And why is this important? Well, again, this is important because if you understand the biology of the tumor specific to that patient, you may be able to target therapies that are helpful for that patient. And so what we've done at UCSF, and this is across all cancers, it's called the UCSF 500 Cancer Panel. We work with the Clinical Cancer Genomics Laboratory, and every patient who undergoes an operation for any cancer can have this panel performed. It's 500 genes that are the highest likelihood of being abnormal in cancer. And we're able to look at the tumor and the normal DNA to sequence to look at both of these. What's germline is what's in our normal cells, and somatic is what's in the tumor. So we can compare what's happening in the normal cells and what's happening in the tumor. And this allows us to really comprehensively detect all of these different things. This is just all of the sequence of genes. And one of the nice things was we had a neuropathologist whose specific works in brain tumors made sure that the genes that are known to be present in brain tumors was on this list, and those are the ones in red. So what happened with this patient when we took the tumor out? We sent it for analysis, and sure enough it had this IDH mutation, that's that one here, but it also had these two other mutations. One was a gene that was amplified, meaning there were multiple copies of that gene. And then there was a gene fusion. In other words, two genes were fused together to form this new protein that normally our cells don't have. So we would not have known any of this if we just said this was a glioblastoma, right? It would have just been saying, okay, glioblastoma, we treat it however we want to treat it. But why is this important? Why is this important is because there are now evidence that this MET fusion that I just talked to you about can represent a drug target, and this was done in pediatric glioblastoma, where you can see the dramatic response this patient had to this drug that targets MET. So crizotinib is the name of the drug, and so now the idea is that we may actually have a treatment for this particular patient who has this abnormality in his tumor. And so this is an idea that we're now launching to actually do this type of analysis for our patients and try to come up with therapies. Here's another case of a patient with a recurrent glioblastoma, and you can see the resection was done. And what we did was this very, very detailed analysis of the tumor itself. And what we found was that this patient's tumor had thousands of mutations. Thousands, not just one or two or three, thousands. And this is a hallmark of tumors that are called hot tumors. In other words, those are the kind that tend to respond to chemotherapy, to immunotherapy, because they have so many different proteins and genes. And so there has been, since May of 2017, the approval from the FDA for this drug, which is a checkpoint inhibitor, it's an immunotherapy strategy, for any solid cancer tumor with a specific genetic feature of this microsatellite instability or mismatch repair deficiency, which actually is what you see in this hypermutated state. And so now you have a therapy that you can actually treat this particular patient based on his tumor analysis with a drug that's available for patients with cancer. So the clinical relevance of this approach is that the hope is that we can use the genomic information to understand what's happening with the tumor, that the change in genetic profile happens across the trajectory of the illness. So what you see in the original tumor can be very different than the recurrent tumor. So you can't tailor your treatment based on the tissue you took out of your initial diagnosis. You have to acquire tissue at recurrence if you want to tailor the treatment. And so for us to be able to guide what we want to do for each individual patient, we need to be able to get the tissue. So these are just some of the trials we have where that's exactly what we're doing. Patients with recurrent glioblastoma, we consent them, they undergo surgery. We do this genotyping analysis, and based on what we find, we either use these types of drugs or we use a tumor board like, which you get together with the genomic experts and we talk about what other drugs we might be able to use. Similarly, we have another trial, precision medicine trial design, where the same thing happens. The patient undergoes screening and they have surgery, and then we do this UCSF 500 panel and try to come up with treatment recommendations using FDA-approved drugs. So it's exactly the types of cases I just showed you, where we're doing this in a formal way with all of our patients. This is the importance of drug repositioning glioblastoma. In other words, these are drugs that are known to be, they get into the brain, And the question is, can these be used? These are all FDA-approved drugs. Can we use these in conjunction with our standard of care to try to improve the outcome for patients? So the last couple of things I want to talk to you about is about immune strategies. And this is where the cancer immunotherapy, you can think about it in two ways, where you want to target the tumor itself with a lot of different approaches. So you already heard about radioimmunotherapy, which is what you heard from the first speaker, about using radiation to antibodies that target the tumor. But you can also activate immune cells, and these are different ways that you can do that, using various approaches like vaccines or viruses. So the different modalities, and this is a very complex slide, but really the main reason I want to show you is that there's a lot of work going on in this. It's very exciting, and we're hoping that we have a breakthrough that we can actually now impart upon our patients the appropriate use of immunotherapy for patients with glioblastoma. So we have a number of trials ourselves where we're using a checkpoint inhibitor for patients. This study is actually ongoing in Australia as well. We have another trial of using combination checkpoint inhibitors. Checkpoint inhibitors are, if you think about it, you have your immune system that keeps going, and you have this break that occurs on the system. That's the checkpoint. And if you inhibit that checkpoint, in other words, release the brake, the idea is that you then ramp up your immune system to be able to fight the tumor. So that's what these drugs do, and they've been very effective in things like melanoma and renal cell cancer. And then we also have an antibody that's used against a specific checkpoint inhibitor as well, PD-L1. So we have vaccines. We have an immunotherapy expert at UCSF who we've worked with to sort of generate these vaccines. And if you think about vaccines, what you're doing is you're sensitizing the patient to abnormal proteins that are present on the tumor cells so that you mount an immune response. So you're familiar with the flu vaccine. So I think, well, for us in the United States, it's currently flu season for us because we're going into fall and winter. But the idea there is that you're using proteins that are specific to the virus, the flu virus, and then your body mounts an immune response. Well, you're trying to do the same thing here with this personalized vaccine for adult patients with glioblastoma. There have been some multiple international studies being done for this. So this is just an example of one that we're doing for patients with low-grade glioma. This is the idea is that we give patients with recurrent grade 2 tumors, and we're actually randomizing them to this vaccination with other agents versus vaccination alone. And we're then operating on the patient to take the tumor out to see if we get a response. Are there inflammatory cells that occurs? Do they drive, do they go into the tumor or not? And then we also do a lot of blood sampling from these patients to see if we see a peripheral immune response as well. So we have a couple of vaccine trials in low-grade glioma patients. The other way that we can use viruses for gene transduction is this particular trial called Toxicity. And the idea here is you take a virus and you use the virus as a vehicle to take a gene into a cell. So the virus actively infects the tumor cells, preferentially, and normal cells, because the tumor cells are dividing. So the virus goes in, it has a gene in it, and this is the gene that therefore has infects the tumor. So you can see the virus is in the tumor now. And the virus begins to spread throughout the tumor. And then what happens there is you then give the patient a drug, a prodrug, and this is 5-FC. So the gene that you're putting into this virus is cytosine deaminase. Just think of it as a gene. But the gene converts this prodrug that's completely harmless and is normal, doesn't affect the normal cells. But in the cancer cell that has the virus, that has the gene converts this prodrug to chemotherapy, 5-fluorouracil. So you're basically putting like a stealth bomb into the cells. You give this drug that's normally not toxic to your body, but because the tumor has that gene, it transforms that drug into a chemotherapy drug and kills the tumor cell. So you have this reservoir of virus that continues to infect the tumor, and therefore you keep giving this drug orally, it's a pill, and then the idea is that you eradicate the tumor. And this has been done now. We're doing a phase 3 trial. I think the accrual is pretty much completed, so we're waiting to see the results of this approach. The other way to think about it is you take a virus and you engineer the virus so that it's not toxic to the body, and you give that virus into the patient, usually through convection-enhanced delivery, which was that delivery I was telling you about, where you put it directly into the brain. The virus gets in, it's specific to tumor cells again, it goes in, it multiplies within the tumor cell and kills the tumor cell. And that's called oncolytic. Oncolytic meaning lysis, meaning death, onco meaning that it goes into the cancer, and it's forced as a virus. So this oncolytic virus is where you're actively infecting the tumor cells. The virus multiplies within the tumor cells, kills the tumor cells, and then the idea too is that you have this release of all these proteins from the cancer cell, and the immune response therefore can activate itself and kill the cells as well. So you have this direct effect of killing, but you also have this indirect effect. And so there have been a number of trials recently. This one was in May of this year, and this is the poliovirus one in June of 2018 that were published that looked at these approaches. One is a Delta 24 RGD oncolytic adenovirus, and this one is the poliovirus, which is recombinant, meaning re-engineered. And so we have this trial open at UCSF, this poliovirus one, where patients will get randomized to either getting a virus with or without a chemotherapy drug, and it's done via CED. So employing a delivery mechanism as well as a viral therapy mechanism. So that's kind of a landscape of clinical trials. I didn't mean it to say that this is only being done at UCSF. I'm just giving you examples of it. There's a number of clinical trials being done. But this need to understand the biology of tumors is how we come up with rational approaches to new treatments. We need to think about how do we get drug into the brain and tailor it to the treatment in the brain itself and not systemically. The hope is that this precision of medicine approach will allow us to effectively individualize the treatments we have for our patients. And this immunotherapy and virotherapy, they're very early being evaluated, but I think it's very exciting that we have so many different ways that we're thinking about how to attack this tumor. So I want to thank my team at UCSF. Couldn't do it without all the work that needs to get done, both in the basic science field, but also in the clinical research areas, and of course, the patients and families who agree to participate in all of these trials. That's just tremendous because we are partners in this road of discovery. So thank you very much.
Imagine there'll be lots of questions after that.
Yes.
Roughly what's the time frame with the injected virus to kill the tumor?
For which ones? So the oncolytic virus ones?
The one where you inject
Directly into it?
Yeah.
So the one where you get the pill, we wait a month before we get the pill. So you want that cancer, you want the virus to replicate enough. For the other ones, it's going to be an ongoing, because these viruses infect other cancer cells. So you get this propagation of infection within the cells. So the idea there is that it's an ongoing effect. There's no sort of necessarily a timeline for when it stops. So one of the things I want to point out is the toxicity, right? So a lot of the early trials that we're doing, the main reason we're doing them is not only to see if it's going to be something that we could study in the future in our patients, but how safe is it and how much can we give so that we don't cause a lot of side effects. And so in the brain, because you might get inflammation in the brain can cause a lot of symptoms like swelling and headache and so forth. So we have to be very, very cautious when we do these types of trials to monitor patients very carefully when we embark upon these things. So just to be aware that phase 1 trials are early phase studies, meaning that we're testing the safety of these treatments. So. Yes?
Susan, do we know, how long does the virus stay around? And is the virus going to be a problem? Does the virus also mutate?
Yeah, so, to do viral therapy in the United States, as you can imagine, the amount of biosafety that has to be done. So for the earlier phases of the study, they did a lot of collection of mucosa like saliva and urine and so forth to try to see if there was any systemic spread. They were able to operate on some patients subsequently to look for whether they still saw virus there, and they were able to. We haven't seen, though, any kind of change in the actual virus itself yet. But they're engineered specifically to target into the tumor cells and not normal tissue. So hopefully that engineering holds up, but it's an evolution, right? Yeah. Yes?
With glioblastomas, obviously you've got to have certain markers to get onto these trials, is that right? Do you have any sort of like ideas, numbers as to how many have the markers and how many don't?
Yeah, so for glioblastoma, 80% of patients with newly diagnosed glioblastoma do not have the IDH mutation. The majority of those patients have other mutations that characterizes them. The idea with some of the genomically based trials is that you care about each individual patient. So when you get the tissue out, you then characterize what is that abnormality within that patient, and are there signals that we can then use to tailor the treatment for that patient. So that's the difference. But your point is a really good one. If you look at some of the approaches for pediatric tumors, for example, and I'm not a pediatric neuro-oncologist, but there are subgroups of patients with specific markers that they are actually doing clinical trials on. And there you have, if the frequency of it is small, you have to screen 500 patients to get 20. And that's prohibitive, right? Because you have to pay for all of that. So some of the work that's being done is some of this biomarker work. Are there blood samples that are easier to acquire? Do we have to get tissue in everybody? And that's where some of the ideas that biobanking blood, for example, on all the patients might give us some insight down the road. But we're still far away from that. But the frequency of the mutation, you're correct, is going to drive how many patients you have to screen to get into your study.
We've been doing some trials at the Mater recently, and Craig might qualify me here, but where we've screened well over 100 patients and we've found one with the abnormality that's relevant for the trial. And it takes a lot of work and a lot of time to do that sort of stuff, unfortunately.
Over 250 patients, and it was only one, it was my patient, and then the drug didn't work.
Yeah.
And we've got a trial, a bit like Susan described, that's running out of the Garvan Institute called the MOST study, where patients with any type of cancer can be screened genomically. And if a particular mutations are found for which we think there might be a treatment, we might be able to link that patient with the treatment. The trouble is, for most of the things we find, there isn't a treatment available or not readily available in Australia. Occasionally, we do find one. We wanted to have 16 different trials running out of that program at any one time, and right now we've got one. I think it's one drug that we can use for.
And then the added challenge in brain tumor patients is that drug even get into the brain.
Yeah, that's right.
So if the drugs don't get into the brain, you don't even have that option, right? So that makes it hard too.
So when people ask why does it take so long for clinical trials to work, it's because it's really complicated and it's very, very hard to move along. So we just have to keep being enthusiastic and keep pushing forward.
And just another little bit of information about viral therapy. There's a company, a small biotech company called Viralytics in this building. They got sold earlier this year for $500 million. And they haven't put a patient on a clinic. Well, no, actually, I put 4 on a clinical trial about 5 years ago in cancers of the throat and tongue and things, and took it a little step further. We could prove that there was virus in cells, and we could prove that there was a reaction by the patient to the presence of the virus in those cells, and that was as far as we got in 4 patients in head and neck cancer. So, with having been sold to a bigger company for $500 million, that concept, like you described, is going to be taken to another level out of this building, I think.
That's great. Thank you all
Okay.
for listening. Appreciate it.
Thank you.
Please hang around. There's plenty more food there. I don't think Marie wants to take it all home to the family tonight, so please eat up. I'd like to thank Susan and Mike for their talks. I'd particularly like to thank Susan for coming all this way and spending the time with us and illuminating us on what's happening on the other side of the Pacific in relation to brain tumour research and looking after caregivers. I'd like to thank Mike for presenting some local stuff, and I'm looking forward to that developing to the next stage, particularly your clinical trial and what happens as a consequence of it. I'd like to thank all you guys for coming and giving up your Saturday afternoon to come and listen and interact. Feel free to talk amongst each other and ask us all any questions you like. We're more than happy to address that. I was thinking on my way here that just before I came, I took the dog down to Bar Beach and sat on a park bench looking at the ocean and the whales in a field full of daisies, which are out at this time of year. So I feel like I've given up a bit of my afternoon for this, but it's been very rewarding for me as well. So thank you all for coming, and again, let us all thank one way or another Mark Hughes Foundation and HMRI for putting this on. Thank you.